It looks like it is noon on my watch, so I think we'll go ahead and get started and want to welcome our listeners and participants to our 2024 Dairy Goat webinar series. We are kind of wrapping up our webinar series here for the year. So we have this one here in October, and I just want to inform the audience to stay tuned for some upcoming webinars that we're going to have planned. I'll be sending those out via email, the dates for the November, December, and then as we develop the 2025 Dairy Goat webinar series, I'll keep you posted via email so that you can start to register for those in the upcoming year. So if you have topics that you'd like to learn more about in the upcoming year, feel free to email those to me or put those in the survey evaluation that I'll include here in the chat box here shortly. But today we're going to be talking about small ruminant abortion diagnostics. And I'm happy to have Dr. Aloyna Michael. She received her DVM from Iowa State University in 2014 and went on to complete a residency and PhD in veterinary anatomic pathology. And then post-residency, she cultivated a strong interest in production animal diagnostics while serving as a pathologist at the National Veterinary Services Laboratory and Iowa State University's Vet Diagnostic Laboratory in Ames, Iowa. And just recently, she joined Auburn University's pathobiology department to further pursue a passion for production animal diagnostics, education, and applied research. Dr. Michael's personal interest in small ruminant pathology is further honed by her own herd of Boer goats who continue to create diagnostic mysteries seemingly for their own entertainment. So with that, I welcome Dr. Aloyna Michael to our Dairy Goat webinar series, and go ahead and start sharing your screen here. Thanks.
Is it not sharing yet?
Yes, it is. Sorry.
It is. Okay.
I had a different screen pulled up, so you're good.
All righty, fair enough. Well, thank you so much for that introduction, and thank you folks for having me. It's good to be back with my Midwesterners, if only virtually. So today we're going to be discussing, again, abortion diagnostic, and I am going to keep this with an ISU VDL perspective. So if you folks submit to the Iowa Veterinary Diagnostic Laboratory, then the diagnostic assays that I kind of discuss later in the presentations would apply to that. So as far as the outline of our lecture, hopefully we're able to get through all of it today. But I'm going to start by kind of discussing some unfortunate statistics about abortion diagnostics, both out in the industry, kind of just some generalizations, as well as at Iowa State. And then we're going to talk about how we can actually go about more successfully working up cases where we have fetal reproductive loss. So we'll talk about the critical importance of history and demographics. We'll talk about gross examination of the fetus and placenta. And then we'll talk about the components of a diagnostic submission and what assays we might have available to us if we do go ahead and send those in for workup. And then at the end, if we have time, I have a couple of neat and classic cases to show you folks. So if you're kind of in the industry, you're aware that there is a certain rate of quote unquote anticipated reproductive failure in our small ruminants, and it does tend to be kind of higher than we see in our large ruminants or cattle primarily. So in cattle, you will have a sporadic reproductive loss of about 1%, but in ruminants, that's quite a bit higher. It's upwards of 5%. So if you are seeing, a 5% or less reproductive loss within your herd, you're actually probably within normal limits, and that falls within kind of the physiologic anticipated reproductive performance of that species. Now, if we do start seeing higher abortion rates than that, then unfortunately we have some poor statistics floating out there in the industry that only about 33% of diagnostic submissions that are shipped off to the lab receive a successful etiologic diagnosis, by which I mean that we determine the exact causative agent of that reproductive loss. So on the flip side, that gives us the unfortunate, again, statistic that upwards of 66% of abortion submissions go underdiagnosed. So they receive a diagnosis of idiopathic or unknown etiology. Obviously, that seems a little bit disheartening. So if that was really true, that most abortion submissions are diagnostically useless, then we probably wouldn't be having this lecture. So I'm kind of here to talk about why we might have such high numbers in that idiopathic category and what we can do to improve those numbers. So those are generalizations. Here's what we actually see at the ISU-VDL. So these are statistics there. I believe they're a year or two old, but I kind of pulled all of the diagnostics that we have for the last few years of abortion submissions in cattle versus in small ruminants. And are actually our statistics for idiopathic versus diagnosed etiology of abortion is actually doing better than the general statistic in that we receive a specific diagnosis in something like 48% of our abortion submissions, and ditto for cattle. Now, when we look at what tools we have at our disposal for kind of screening for infectious causes of abortion in ruminants, on the bovine side at Iowa State, we have the bovine abortion panel, and on the small ruminant side, we have the small ruminant abortion panel. So in red in those little pie charts are the entities that are represented within our abortion panel. And you will notice that in cattle, only 5% of our abortion submissions get a positive hit on the abortion panel, versus in small ruminants, upwards of 26% of our small ruminant abortions receive a hit on the small ruminant abortion panel. So that's quite an interesting disparity there. It seems to make it look like the small ruminant abortion panel is more successful, but we have to consider what might be behind those numbers. So one of the top things that might be contributing to kind of the low hit rate of the bovine abortion panel is vaccination availability, use, and efficacy. You will notice that we have vaccines against, as far as I know, 3 out of 4 of those bovine abortion panel agents. And they are reasonably successful if used appropriately, versus our availability of vaccines on the small ruminant side is quite a bit lower. Other things that might feed into that higher supposed rate of SRAP positive hits might be the threshold of concern prior to submissions. So our bovine clients might be more concerned about sporadic abortions than we see in our small ruminant clients, again, because of the higher propensity of our small ruminants to have kind of background reproductive losses. The other thing that might feed into the generally, again, large number of idiopathic or not specified diagnoses on these abortions is going to be submission completeness. And we're going to talk about that at length down the line. So when we talk about definitions of reproductive failure, it's important to note that fetal loss can occur at any point during gestation and even shortly in the perinatal periods. So if we have early embryonic loss before that fetus has actually started mineralizing its skeleton, as we see on the left here, we would actually have resorption of that fetus, and that would manifest as return to estrus. When we talk about abortions, what we're discussing is expulsion of the fetal prior to gestational maturity. So in this middle image, you see that this fetus is hairless. So that is an indicator of immaturity. And then we can have stillbirth. Stillbirth is defined as the expulsion of a dead fetus at its normal due date. So these are full-term fetuses, but they exit the vaginal canal non-viable. Then finally, we have perinatal loss. So here we have this particular goat. He is fully haired. This chap is full term. But if we pop open that chest cavity and we see inflated lungs, so these are lungs from a fetus that was ostensibly aborted or stillborn, these lungs are inflated and floated in formalin, which tells it that this is actually perinatal loss or failure to thrive. And various diseases and various disease processes can hit at different stages of gestation and kind of narrow down our differentials. And we'll talk about that down the line. So again, when we're talking about general mechanisms of fetal deaths, we have to consider both non-infectious and infectious causes of reproductive loss. So general categories of our non-infectious causes of reproductive loss include sporadic, nutritional deficiency, toxicity, and iatrogenic effects. So under the sporadic category, we always have to consider a biological oops. Something went wrong in that individual fetus's formation where it could not actually continue to maintain a viable pregnancy through parturition, and that fetus is resorbed or potentially aborted. The second category that is really truly a major one is maternal stressors. Recall that any environmental, nutritional, social, or handling stresses that are placed on the dam could actually induce abortion. Notably, I don't personally have experience with Angora goats, but it seems like in the literature, they seem to be more quote unquote stressy and prone to stress-mediated abortions. Usually these stressors are sporadic, but obviously we can have herd level effects if we have a severe environmental event, poor weather, heat stress especially can cause this. So we can see stress cause larger numbers of reproductive losses. Nutritionally, we have to keep in mind that certain deficits can have very clear presentations in effects on the fetus itself. So you're all familiar with iodine deficiency causing goiter. If we have a copper deficiency, that can manifest with ascending paresis in the young neonate. We call that enzootic swayback. If we have certain other deficiencies, such as manganese, that can cause an impact on bone formation, and you can see weak or malformed fetuses in cattle. This often manifests with chondrodystrophy. Then if we move on to toxicity, this is a little bit more unusual in the small ruminant side of life, especially in the Midwest. But we have to keep in mind that if these animals are grazing on goiterogenic, teratogenic, or nitrogen accumulating plants, you can see reproductive effects from that. And then finally, iatrogenic, snafus happen. Sometimes we may forget that albendazole administration in the first trimester can be teratogenic, so we need to avoid giving those dams that particular product. And then administration of dexamethazones or prostaglandins inadvertently or in treatment of a different non-reproductive condition can in fact induce expulsion of the fetus. So that's our non-infectious cause of abortion. When we talk about infectious cause of abortion, there are sporadic and non-contagious infectious causes of abortion, by which I mean that these are caused by exogenous agents, but they cannot be then transmitted to herd mates. So these can be sporadic, or you can see them in larger numbers, but the key part is that herd intervention is not immediately necessary because that cannot be transmitted to herd mates. The one that we really care about is going to be abortion storms. So abortion storms are when we see synchronous or rolling losses in multiple dams. So again, if we exceed the 5% threshold, or Lord forbid, we get into the 20% plus loss, that is strongly suggestive of infectious contribution to abortion. And we really want to get those particular fetuses and placentas into the diagnostic lab to determine what caused it and what interventions might be undertaken. The important thing to note here is that in small ruminants especially, some of our key players in abortion storms will primarily manifest as abortion storms in naive herds. So if we have naive animals, new animals to the herd, or those animals have never seen this infectious agent before, they will have abortion. But in subsequent years, they do develop a degree of immunity, and that agent becomes endemic rather than epidemic. So you will have sporadic losses in your first timers down the line, or any naive replacements that you bring into the herd, but hopefully that abortion storm event should not happen again as long as we maintain a degree of immunity in the herd. Sporadic causes of infectious abortion that again are less transmissible are going to be protozoa, so usually toxoplasma. And then we have our non-contagious causes of infectious abortion. And here I'm primarily talking about our arthropod-borne viral infections. So something like Cache Valley virus, where the mosquito can vector the virus to the individual dam, but the virus cannot then be transmitted from the dam to her herd mates, either directly or even with contact with the abortive material. So again, these are non-contagious. And then again, especially when we have older animals that might have had some kind of trauma, reproductive trauma previously, you can see sporadic cases of ascending bacterial infection through those leaky cervixes that again would be of lower herd health concern. So where do we start with abortion diagnostics? The thing that is often overlooked in our submissions is the critical importance of herd history. So when you have one of these events happen at your farm, it is critical that you work with your veterinarian to compile as complete a herd history as possible. The critical components are going to be the questions that I have there. So how many of these animals are effective? What is the timing of the losses? Are you losing losing one here or there, or are you suddenly seeing a bunch of fetuses lost within the span of a couple days? The gestational age of the fetuses, is it appropriate for what you thought the gestational age was? The demographics, are these first timers, primiparous, or naive animals? Were these guys home raised or were they purchased? What is their prior reproductive history? Have they previously carried a fetus to full term? Again, all of those are going to be critical. We also need to keep in mind the local conditions. So again, what's recently changed? What could have brought this on? Are we aware of stressors? Did we recently ship these animals? Did we recently move pastures or barns? Was there some kind of environmental stressor or weather event that could have precipitated stress and induced abortions that way? Did we change feed? Did we move animals or did we introduce animals? Did we shake up the herd order where those newly introduced animals might have been bullied and aborted thereafter? Or did we perhaps again introduce an infected animal without an appropriate quarantine period, thereby triggering abortions in your native herd? Again, all of these are going to be critical. And finally, we really need to take a close look at the presence or absence of maternal morbidity. So that's the first part of our examination, is to know whether or not those dams are exhibiting clinical signs. There's a couple reasons for this. One reason is that, again, abortion can be induced as a function of maternal stress or morbidity. So if your dams have an outbreak of pneumonia, you might see abortion fall out on the back end of that because that dam was pyrexic and sloughed the fetus that way. So again, that is an abortion induced by maternal factors and presumably would not then be transmitted to herd mates. The other thing is that some of our abortifacient agents, they are notable for either causing or failing to cause maternal clinical signs. So you will notice that on the left there, toxoplasma and most of our viruses that target the fetus specifically do not cause maternal clinical signs. Some of our endemic agents, again, especially in our older dams, will not cause clinical signs in the dam herself. But other infectious agents, such as Listeria or Salmonella, can actually show up with pyrexia and metritis on the back end. So it is important to know whether the dams are exhibiting clinical signs before or after the abortion event. You also really want to take a look at the body condition and any other clinical abnormalities or comorbidities that might be present within the herd that can help inform whether the reproductive loss is a primary abortifacient agent-related event or whether it's a sequela of something else going on in the herd. So now we're going to talk about the gross examination of the placenta and fetus, and I have to flash this warning up. Please keep in mind that multiple of our agents that are abortifacient in our small ruminants are actually zoonotic, and because of that, pregnant and immunocompromised persons really should not handle fetuses and placentas if they are found. Again, keep in mind that the worst hitters here are going to be Coxiella, Toxoplasma, Brucella, reasonably rare in the United States, but need to keep that in mind, and more rarely Chlamydophila and Campylobacter can cause clinical signs in humans. So make sure that you inform your farm staff, your producers, that they need to watch out for this and not put themselves at risk if they are in those high-risk categories. All right, so if we're looking at placentas, there are two main things that we need to look at. So the intercotyledonary space and the cotyledons themselves. So here we have the intercotyledonary space, here we have the cotyledons. The cotyledons serve as the primary exchange site of nutrient and oxygenation to the fetus, whereas our intercotyledonary space just conveys the vasculature and links these all up together to then link up at the umbilical cord. So our intercotyledonary space needs to be very clear. It needs to be thin and membranous. You should really be able to see right through it. So I used to have a professor that told us that you need to be able to read a newspaper through a small ruminant's placenta. And unfortunately, I never did have a newspaper on hand when I got one of these. So there's how clear that ought to be. Now you can see the table right through that. So that is normal. The next thing we need to look at is the shape and size of the cotyledons. It's important to note whether the cotyledons that are next to each other are more or less normal in size, shape, and color. If there is deviation or variation in the size, shape, or color of particularly adjacent cotyledons, that can be indicative of an inflammatory exudate and therefore suggestive of a infectious contribution to that abortion. So now let's talk about color. So here I have your one and only poll of the day. This is a real tough question. Could I get a vote from you folks as to which of those placentas looks normal? Which one is normal? Is it A, B, or C? Now you might notice that those look a little bit funny. These are actually cattle cotyledons, and those tissues have been fixed. But the general color schema is more or less transferable. So can we get a poll of who thinks or which one of these we think is normal?
All right, Dr. Michael, I did launch the poll. Are you able to see that?
Yep, I am.
Okay. So we'll give people a few minutes here, or not a few minutes, a few seconds here to
Uh-huh.
um, put their choice in. And looks like we had about 20 participants on here. So
This is low stakes, folks. Make a vote.
I see one rising to the top. So I'm gonna go ahead and end the poll here and I'll share
Okay.
those out for you. So you should be able to see those. It looks like B was
Oh, B. Excellent. All right. So the reason I said that this is low stakes, thank you folks for voting. The reason I said this is low stakes is because all three of those placentas are in fact normal. So the reason we're getting into this discussion is the following consideration. Remember that the placenta is a highly vascularized organ where maternal blood vessels and structures interdigitate with fetal structures. And when the placenta is expelled, here's what that looks like microscopically. So here we have the maternal stroma, and this is the fetal placenta. Note how very closely those are opposed. So when a placenta is expelled, we necessarily have physiologic damage to that highly vascular organ, and the result is bleeding. Those pictures that you saw to begin with, they're from this paper. They evaluated bovine fetal placentas after normal parturition events. So these were completely healthy pregnancies, and they looked at the gross and the histologic appearance of those placentas. And again, color doesn't matter as long as it is consistent between the cotyledons. So that color is going to be determined by the amount of time that passed between the expulsion of the placenta or the separation of the placenta and the expulsion of a placenta. A freshly sloughed placenta would look like this. So it would be nice, bright and pink, generally transitioning to darker red. If that placenta is held within the body for, 8 hours or so, we'll start breaking down that blood, and those cotyledons might start looking a little bit darker browner in color. And then if we actually retain the placenta, that dam's body will actually break down all the blood byproducts here. And if you've ever seen a retained placenta, they're often almost completely colorless or ghost-like in appearance. So again, the critical factor isn't the overall color, but differences in color. And here's what I'm talking about there. So here in this cotyledon up top, you will notice that most of the cotyledon is a nice red color, but here we have these flecks of fibrin and exudate. So here's what that looks like fixed. So that really pops up the contrast between the normal red cotyledon and the fact that we have variation in color in that we are producing exudate that is covering that cotyledon. Here we have another placenta. So if you take a look at this one, this cotyledon here is half red and half white, which again tells us that there is exudate and says that this is an infectious abortion. And again, here we have differences in the sizes of these cotyledons that are next to each other. So again, we look for differences in color across a cotyledon, between a cotyledon, to tell us whether there is exudate there. And here I have more examples of intercotyledonary placenta. Remember, I told you that we should be able to see right through it. And here in this example, you can see my glove in the background, and you cannot see my glove through that particular placenta. So we have marked thickening of the intercotyledonary placenta, which tells us that there is an inflammatory exudate in here, which says that this is, again, infectious. And we have similar examples on either side here of abnormal placentas, thickened intercotyledonary placentas, which again says infectious. Now, we also have to keep in mind that there are certain, not necessarily placental changes, but certain background features of placentation that are within range of normal. So one submission that we'd get every now and again is a concerned producer would see something like this these white little raised plaques on the amniotic sac. So not on the cotyledonary placenta, not on the chorion, but on the amniotic sac. These are amniotic plaques, and these little boogers are produced normally. This is a completely normal feature of placentation. They can increase in size and density as we approach the umbilicus, but again, that's normal. The other thing to keep in mind is that we can have necrotic tips at the very edges of our placenta, but most of our cotyledons ought to be nice and viable looking. And then if we had evidence of prior uterine trauma, you can start seeing adventitial placentation or lots of smaller and misshapen cotyledons next to more normal ones, which is an attempt by the fetus to get more oxygenation. So again, make sure that you take a look at your placentas. Hydrant is going to be your friend. Make sure you rinse that off and take a look at it. See if you see any exudate, any concerning variation in colors, lack of transparency in the intercotyledonary region. And if you see that, you should send that in because that suggests that this is in fact infectious. All right, what have we got here? So again, if we've got exudate, that means an inflammatory reaction. If that exudate is affecting both cotyledons and the intercotyledonary region, as we saw in the placental example a few slides back, then that is suggestive of bacterial or fungal placentitis. So again, if the exudate is on both the cotyledon and the intercotyledonary region, then we're thinking bacterial or fungal. Now here we have something different going on. So here we have a enlarged cotyledon that has these white specks that almost looks like a meatball with rice specks in it. So these rice grain areas, these are areas of necrosis. So this is abnormal, but notably the intercotyledonary region on the bottom left here is perfectly fine. It's very nice and see-through. And this is a characteristic very specifically of protozoal placentitis caused by toxoplasma. So again, if we have cotyledonary necrosis, but no cotyledonary reaction, toxoplasma would be top of our list differentials. So for diagnostic considerations, make sure that you collect your placenta as long as it hasn't been eaten or carried off by the dog. Make sure that you fix it and save it fresh. But also keep in mind that a placenta, if it is external to the body, it is by definition contaminated. So it's going to be contaminated by vaginal commensals and environmental commensals, which is why culture of the placenta is sometimes a fraught subject, and we should kind of consider collecting additional samples such as fetal stomach contents, which mimic the amniotic fluid that is around the fetus. All right, so that's placenta. Next up, we're going to have a quick chat about examination of the fetus. So things to pay attention to are gestational age, evidence of putrefactive or sterile death, and presence or absence of fetal defects. So when we look at the fetus grossly, there's a couple things we can make note of. So one is going to be the degree or the size of that fetus, and the second is going to be indicators of maturity. So the size of the fetus, you can find charts out there on the internet. So we measure the crown rump length from the forehead to the rump there, and we can compare it to charts that can tell us about how far along that fetus is. In certain other animals, especially in cattle, you can actually take measurements of the head length and head width as well, and you can even do that on ultrasound and compare it to a general growth chart to tell you how old that fetus is. That is a little bit more challenging in our small ruminant side of life because that is in fact breed dependent. So obviously your pygmies are going to be smaller in size than your boars or your other dairy goats. So again, that is breed dependent. The other things that we can make note of are going to be evidence of maturity. So there are certain landmarks that we hit. So the gestation of a small ruminant is about 21 to 22 days. And so we will notice that certain things start popping up at certain stages of gestation. So if your eyelids are able to be separated, you're kind of here in mid-gestation. And then as that fetus is in the last trimester, we start accumulating here and erupting incisors kind of within that last week of life. So again, we can look to these landmarks to determine how far along those fetuses are. The next thing that we really need to look at is going to be evidence of inflammation in the fetus and the placenta. Again, if we have placentitis that is very acute, the fetus might not have a lot of lesions. But if the fetus itself is infected, you can have a kind of a spectrum of changes that you can see. One can be inflammation within the fetus indicative of necrosis and exudate. So on the top right here, we have an absolutely classic targetoid hepatic necrosis that can be seen with Campylobacter infection in the fetus. And on the bottom right, again, this is Campylobacter septicemia in the fetus, where we see this pus and fibrin accumulating on the surface of this particular liver. So this is indicative of a fetal inflammatory response, and that again tells us that this is an infectious entity. On the bottom left, we have the progression of that bacterial infection. Again, bacteria, they like to reproduce. They get into a fetus. Once that fetus is dead, they treat it like a petri dish and they go nuts. And when they go wild, they can actually macerate that fetus or cause digestion of the fetal tissues. And if that fetus already has calcified bones, then all you might find is a putrid sac of extremely foul-smelling material. If you've ever smelled it, you'll never forget it. And all you'll find on the inside that is identifiable is going to be bones. So again, if you have fetal exudate, that is indicative of a fetal inflammatory response. Or if you have maceration of the fetus, where you have an emphysematous, very foul-smelling and basically a digested fetus, then that is indicative of presence of bacteria in utero that have overproliferated. Now, those bacteria might actually get in there opportunistically, but again, this is an indicator of bacterial presence in the uterus. So when we see these things, we have to think about our bacterial differential. So obviously, these guys are going to be of our high herd health concern at the top here, versus here, these guys might be either ascending like E. coli or potentially hematogenous opportunistic agents that happen sporadically here and there, but should not cause abortion storms necessarily. And then fungal placentitis, we don't see this quite as much in our small ruminants, but again, you can see placental inflammation and some inflammation on the skin of the fetus if that is what's happening. So what diagnostic considerations, if we see this, we have to consider that not all of our bacterial agents can be recovered on routine culture. So for example, Chlamydophila, we really don't have routine cultures available that can recover that. So even though you have the exudate, yes, it says it's infectious, you might not be able to recover it on routine culture. And then again, consider the possibility of opportunistic infections that are not of high herd health significance, where it's an ascending commensal from the vaginal tract got through there through a leaky cervix. So that's our pyogenic or putrefactive fetal death. Next, we're going to talk about non-putrefactive or sterile fetal death. Now, when we talk about sterile fetal death, that's not saying there isn't an infectious agent. It's saying that it isn't bacterial. So you can have non-putrefactive fetal death with fetal death from potentially stress, potentially compromised placental oxygenation status, viral infections and protozoal infections, where that fetus is no longer viable, but it's not immediately expelled, and so it starts decomposing within the uterus. But because there isn't a bacterial component to it, then these fetuses undergo what we call autolysis rather than putrefaction. And the eventual end product of that is mummification. So I'm kind of going to go through this series of changes that you might see in a fetus that is on its way to mummification. So when we have a fresh fetus, we have normal coloration to our musculature. And again, this is a very fresh fetus. We have nice full eyelids, so no evidence of in utero decomposition. 12 to 24 hours after the fetus is dead and maintained in utero, you have early evidence of decomposition. So one, your corneas might get cloudy, and then the more telltale thing is that you will have a reddening of the musculature and then accumulation of this serosanguinous interstitial fluid as the blood vessels in that fetus break down and that interstitial fluid accumulates within our potential spaces. After 36 hours, we will gradually start seeing even more advanced evidence of autolysis, where this interstitial fluid starts accumulating in the subcutis. And unfortunately, I don't have a picture of this here for some reason, but your eyeballs will start dehydrating. And instead of being nice and full, they will sink downwards relative to the contour of the orbit. So dehydration of the eyeball, this brick red discoloration to all the organs and the musculature, we call that imbibition of hemoglobin, and accumulation of this gelatinous interstitial fluid in both potential spaces in the subcutis indicates that that fetus has been cooking in utero for some time after loss of viability. And finally, over time, the uterus will start resorbing some of that water and progress that fetus towards mummification. So the requirements for mummification is that we have calcified our bony structures and we don't have presence of bacteria in the uterus at time of fetal death. So effectively, the water will become resorbed out of the fetus. So you will notice that there is no more fluid in the thoracic and abdominal cavities, and our organs start becoming dehydrated. So they will assume this kind of putty-like sticky texture. Our eyeballs will be fully sunken into the globe. And then again, at the far end of that spectrum, we have a full mummy where that fetus is now shrink wrapped around its skeleton with very little soft tissue left. This guy isn't totally far gone, but he's getting there. So again, fully sunken eyeballs and mostly just skeletal structures left. So what does it tell us if we have changes in the fetus that are suggestive of progression to mummification? Well, it can tell us that this was a non-infectious cause of abortive loss, or that the infectious agent is more likely to be viral or protozoal. So viral and protozoal agents, they do not stimulate that severe inflammatory reaction. They do not continue digesting the body post-death. So you will have progression towards mummification with viruses and protozoa. The one exception to bacterial infections along that line, where it's a non-pyogenic fetal autolysis, is listeria. Listeria can also cause or feature mummification as a finding post-expulsion. So again, because our top infectious differentials are viral protozoal, our culture is not going to be helpful. So we're going to be targeting our PCR, serology, and potentially considering some toxicologic or nutritional testing on that end. And then our last finding that we can have in our fetuses is going to be fetal defects. The three main causes of fetal defects are going to be viral, toxic, or nutritional, and spontaneous kind of genetic snafus. So here you have a picture of Cache Valley virus infection in a sheep. So this fetus is completely rigid. These legs are fixed. They cannot be moved. This tail is completely rigid as well. Here we have our opened calvarium and our spinal column, and we will notice that where there's supposed to be a cerebellum rather, there isn't. So we have severe cerebellar hypoplasia and arthrogryposis of this fetus. And again, some of our viral agents, and especially Cache Valley, are going to be our top differentials there. Toxic and nutritional issues can again present with fetal malformation. So you folks are probably familiar with the trilogy of findings of iodine deficiency, where we'll obviously have bilaterally symmetrical hypertrophy of the thymus. We will have superior brachygnathia. So notice that the maxilla there is shorter than the mandible. And we have general hairlessness of the fetus with exception of the extremities. This fetus here was actually born alive. He was full term, but that iodine deficiency induced these changes in here. Over here, we've got manganese deficiency. So these are very foreshortened femurs here. So manganese deficiency can cause chondrodystrophy. And here we have the constellation of changes that we might see with severe gestational vitamin A deficiency. So we can see cleft palate formation, microphthalmia or anophthalmia. What I don't have in here is you could also see hydrocephaly. And then vitamin A deficiency can also induce formation of ventricular septal defects. So here you see me introducing forceps through a ventricular septal defect into that right ventricle there. And then finally, spontaneous genetic defects. Sometimes species happen and you can just have severe anomalies in fetuses that are one-offs. So these are all defects in a single fetus. We have atresia ani, so failure to form an anus. We have ectopic heart formation. So I did not incise into this chest cavity. The heart was just hanging out on the outside of this fetus. This fetus also had failure to fuse the abdominal wall. So all of his entrails were just hanging out with him within the amniotic sac. And he also had syndactyly or fusion of those digits. So again, this is a spontaneous genetic thing. It is not a risk to the rest of the herd. So if we're looking at fetal defects, some of our diagnostic considerations are that the insult likely occurred early in gestation. So if this was, for example, viral, that virus may no longer be present within the maternal or fetal body. So we need to consider collecting serum from the fetus or the dam to see whether there was an immune response mounted against the virus, because again, that virus may no longer be detectable in the body. If we're thinking nutritional, we really need to take a look at the nutritional status of the dam, not just of that fetus. So we want to consider serum and liver biopsies. But the other concern there is going to be if it was a toxic exposure, then that was transient, and oftentimes that toxin is no longer detectable if we even have the assays to detect that agent. So in that case, we need to evaluate our exposure risk, evaluate our pasture, see if there were teratogenic plants in that pasture, or if perhaps, again, we administered some pharmaceutical products that are associated with teratogenesis. So here's our diagnostic decision tree. So if you have increased abortions, how can you bop through this tree and decide whether or not there is an infectious cause? And if there is, what diagnostic assays do we apply to that? Well, here we go. So if we have evidence of fetal or placental inflammation, so yes, we have fetal or placental inflammation, that says that there is a fetal or maternal inflammatory response, and therefore this is likely an infectious abortion. So we want to culture for viable bacteria or run PCRs for bacteria, viruses, or protozoa. So if we culture and PCR and we're still negative for everything, we need to consider some alternative explanations. So one could be that this is a fastidious agent. So chlamydophila and ureaplasma cannot be isolated on routine culture. So that might account for a quote unquote false negative there. Two, we might have cleared that agent by the immune system. So again, some viruses, chronic viral infections can be cleared. So by the time the fetus is expelled, the virus is no longer detectable. So we need to consider serology in those cases. And finally, the possibility is that zebras do sometimes happen. So this could be a novel agent that we don't have commonly available diagnostics for. In that case, we can consider some more novel diagnostic techniques such as next generation sequencing. Now, what if we don't have any evidence of fetal or placental inflammation grossly or histologically? Well, there's some options. If we still have a quote unquote abortion storm, then consider either environmental factors or possibly a toxic exposure event. So those are still possibilities. The other option is if these are sporadic events, they're inconsistent in presentation, especially if stillbirth and failure to thrive, so perinatal reproductive losses are seen, we really need to consider the possibility of nutritional deficiencies. Now, what to do if you have fetal malformations? Remember that these are chronic, and your top three differentials are going to be viral, deficiency, or toxicity. For viruses, since these are hit and run, again, we need to consider serology because the virus may no longer be detectable. If we are looking at deficiencies, we really need to evaluate our fetal and maternal serum. And then if it is a toxicity event, we really need to get an accurate history of any pharmaceutical products that were administered or walk the pasture and see if there's any evidence of teratogenic plants. So if we're talking about general sampling strategies, the absolute minimal data set that we need in order to rule out infectious and high herd health significance contributors to the abortion is going to be the fetus and the placenta. That is the absolute minimum. So if we have infectious cause of abortion, they can get to the fetus either hematogenously or through the amniotic fluid. So placenta is going to be critical for both those routes. And for hematogenous, we need the fetal liver. And for ascending or amniotic infections, we need lung and stomach contents. If we are suspecting a prior infectious event that is no longer present in the fetus itself, we need maternal serum or fetal serum, which is going to be that thoracic fluid. If we're thinking that this is a nutritional event, then we really need fetal liver as well as maternal serum and or liver biopsy. So here's a nice little chart. So again, the minimal, absolute minimal data set is the fetus and the placenta, but I would add that it would be very helpful to also receive maternal serum. Now, again, small ruminant fetuses, they can be submitted whole to your diagnostic laboratory, and I'd recommend doing that if you are able. But if you are unable to ship the entire fetus, here are the tissue sets that we most commonly harvest on the floor from our whole fetuses. So we need lung, heart, liver, kidney, diaphragm, or tongue, thymus, brain, stomach contents, and fetal thoracic fluid. That's what FTF stands for. Why is it so complicated? Why do we need all of these tissues harvested from these fetuses? Well, the problem is that lesions and infectious agents can localize to different organs depending on what's causing them. So viruses like to hit lung, liver, spleen, maybe brain. Protozoa are going to localize to the brain and muscle and maybe the placenta. Bacteria, you're going to see lesions. I should have lung in here. You should see lesions in the lung, liver, and you need to culture it from stomach contents, and you might see lesions in the placenta. Fungi are primarily going to be in the placenta. And then if we're looking for nutritional causes, we need muscle for lesions and liver for testing. The other problem, again, is that not all etiologies are detected in the fetus alone. That's why we need this placenta, maternal serum, and fetal thoracic contents. So certain agents are hit and run, so our viruses and protozoa. In that case, we need to run serology. And then again, remember that some of our toxins may no longer be detectable, or they may be highly labile, so they may gas off of the fetus if we do not collect those samples appropriately. So here I've got a chart here. I think I may have put this in your notes, so I'm not going to belabor it too much further. But what this is trying to demonstrate is, again, the importance of a complete tissue set and why certain agents may not be able to be ruled out if we don't receive all three of those pieces. So the fetus, the placenta, and maybe the maternal serum. So our viral agents, they do not have gross lesions in the placenta, and they are usually not detectable in the placenta. So if all we receive is placenta, you may get a false negative diagnosis. Your bacteria, for the most part, your bacteria will have lesions in the fetus and in the liver, and we should be able to pull it out of both. But a notable example is Coxiella burnettii. Oftentimes that one, for whatever reason, likes to just stick to the placenta, and we may not have fetal lesions. So we may have a false negative diagnosis if we only receive placenta. And then let's see here. If we're talking about protozoal, these guys are usually present in very, very low numbers within the actual tissue. So histopathology alone may not be successful in finding them. So we may need to rely on our molecular testing, and we really, really need to include a pool of placenta, brain, and fetal skeletal muscle in order to be able to find our protozoal causes of infection. Alrighty, the other thing that's important to consider is proxy sampling. And so what do I mean by that? So first, let's talk about fetal thoracic fluid. Remember I told you that when you have autolysis of the fetus in utero, so the fetus is no longer viable and it starts decomposing in utero, but there isn't a bacterial component, that interstitial fluid will start accumulating in our potential spaces. And this is diagnostic gold because this is basically an equivalent of fetal serum. Remember that we don't have passive transmission of immunity from dam to fetus in utero. That's why colostrum is so important. So if we detect antibodies against an infectious agent in a fetus, that implies that that fetus was in fact infected in utero. So again, that is diagnostic. So if we have a hit and run agent, especially our viral agent, maybe some of our protozoal agents, that fetal thoracic fluid is very helpful because again, we can use it for fetal serology. The next thing to consider getting is we really want those stomach contents. So remember that fetuses make rudimentary respiratory motions and they perform swallowing motions in utero. So they're constantly swallowing amniotic fluid. And so post-birth, our stomachs are usually full of this thick mucinous amniotic fluid. That amniotic fluid is representative, or that fetal stomach contents is representative of amniotic fluid that was present around that fetus at the last point in time that that fetus was alive and swallowing. So it is a perfect mock-up of that amniotic fluid. We really like to use that for culture. So recall that our placentas get contaminated when they pass through the vaginal vault and then fall into a poo patty on the ground. But those fetal stomach contents are contained, and they are more likely to remain sterile in a clean fetus or have a high concentration of the true infectious agent in a bacterial amnionitis. So again, fetal stomach contents are excellent proxy for amniotic fluid, and we use those for culture. Maternal serum is the next thing that we're going to talk about. So maternal serum, we can use that for serology, but if the dam has antibodies, all that says is that that dam was exposed. It does not guarantee that that exposure is what caused the abortifacient event. The other thing that we can use maternal serum for is going to be, in blood, is going to be nutritional testing. So we can run trace minerals on it, vitamin A and D. I'm not sure why I only have vitamin D on there. That should say A, E, and D, as well as trace minerals. It is important to make sure to obtain an unhemolyzed sample. So here I'm showing a hemolyzed sample that will throw off nutritional testing. So we need to spin that sample down and get a non-traumatic stick. The last ancillary sample that we might want to get is going to be maternal liver. So chronic deficiency gestationally, that is a function of maternal deficiency. And so it's really the maternal liver that is going to be the most informative, especially if we're worried about vitamin A deficiency, because in fetuses, they can be gestationally deficient, but even normal fetuses have relatively low quantities of vitamin A in their liver. So we want maternal liver for that optimally. It's important to note that our usual tools for liver biopsy are the standard TrueCut biopsy, and the yield for that is 10 milligrams of tissue. You usually need 20 milligrams of trace minerals, so you would need 2 sticks for that. And notably, this is not terribly feasible for vitamin testing. You need a larger purpose-made kind of trocar to get sufficient liver biopsy for vitamin testing. So in that case, you might be forced to use serum. So here again, I have a reminder that our optimal sample list is the whole fetus, placenta, and maternal serum. And again, a reminder of why we need all of these tissues is that certain infectious agents localize to different parts of the fetus. So this is the small ruminant abortion panel that is available at ISU. You will notice that most of our viruses, they're only going to be detectable in the fetus. So receipt of placenta alone is you can miss the diagnosis. Most of our bacteria are going to be present in the placenta and the fetus, with exception of Coxiella, because that one likes to just stick to the placenta. So again, underlining the importance of receiving a complete tissue set. I've included this particular table in your lecture notes, which should be downloadable from the chat window there. We're running kind of low on time here, so I'm going to skip over it. But what I've done here is given you a list of the most common ancillary diagnostic modalities that we use on the D-Lab side to see whether there is an infectious agent present. And it tells you the purpose of that diagnostic assays, what samples we need for it, how it's useful, and then what are kind of some of the potential suboptimal factors of that particular diagnostic assay. So again, that is available for you folks to download. Alrighty, so now let's get back to the statistics that we had in the beginning, where we said that 60+% of abortion cases are quote unquote non-diagnostic, so we fail to find an etiologic agent. And again, this is not actually the cause for despair that it seems to be. It doesn't mean that abortion submissions are useless. So why are we submitting these? Well, because we need to rule out diseases of high herd health significance. So we need to make sure that that one abortion event is not a harbinger of an impending abortion storm where we need to take immediate action to protect the rest of our crop for that year. So again, you're submitting this to rule out that this is an individual event versus a potential high herd health concern. So what are some causes of diagnostic failure or failure to determine a specific etiology for that reproductive loss? The number one cause, far and away, is that we receive incomplete submissions. Again, the dam eats the placenta. We can't find the placenta. The dog took the placenta, or the dog took the fetus and ate it. And we only receive maybe the fetus, maybe receive the placenta, and we almost really rarely receive maternal serum. So if we don't have all three of those, we can fail to diagnose the presence of an infectious agent because of an incomplete sample set. The other thing is incomplete testing. So remember, for comprehensive testing, we need to culture tissues. Well, first mainstay, we need to do histopathology to look for inflammation. We need culture, we need PCR. Ideally, we need serology to really fully comprehensively rule out the presence of an infectious agent. And recall that certain agents are fastidious. So again, ureaplasma, mycoplasma, chlamydia, they cannot be recovered on routine culture. Some agents are hit and run, so they are no longer detectable in the fetus at time of expulsion. So in that case, we really need that serum for serology. Other possibilities is that, again, probably the vast majority of reproductive losses, they are non-infectious in nature. So they can be nutritional, toxic, environmental, or especially maternal morbidity, whether that's stress, whether that's systemic disease in the dam. She has a bout of pneumonia and sloughs the fetus. Toxicity and deficiency in the dam is possible as well. And then again, remember in our litter-bearing species, periparturient metabolic disease in the dam is a big problem. So ketosis is a possibility or a possible cause of reproductive failure in that animal, and we cannot diagnose that from the fetus or placenta alone. Alrighty, so what do we do if we do have a suspected infectious abortion event? Well, again, we need to be proactive. Hopefully, on the front side, we've been separating our first timers from our mature dams. So remember that our first timers are going to be naive and more likely to abort if we have an endemic agent in the herd. So any new replacements should also be quarantined away from our mature herd. We need to practice biosecurity measures to limit cross-contamination of any of our feedstuffs, our boots, our choring clothes, especially if we, well, I'll get to that later. We also should consider avoiding ground feeding. So if we have an abortion event and we're feeding hay and grain on the ground, that is going to increase the chances that those animals are going to become infected by any abortifacient agent present in the exudate. Now, if we have an abortion event, it's very critical to contain that event and prevent exposure of currently gravid animals. So we want to make sure to ideally remove the fetal membrane in fetus and separate that dam during that period during which she has that lochia where she could still be shedding any potential abortifacient agents. Ideally, again, we'd take our the rest of our currently gravid animals and move them away, but obviously space constraints are a thing. So at minimum, we need to remove the animal that has aborted until we can demonstrate that this was not an infectious abortion. And then obviously the key thing that our producers are going to be concerned about is how do we treat this? How do we prevent this? How do we keep anybody else from aborting from this? Obviously, treatment considerations are going to be etiology dependent and will require you to work very closely with your veterinarian. Please note that some infectious causes of abortion have no treatment. So we do not treat for Coxiella or Brucella. Viral abortions don't have a treatment. So these are things that might require some management considerations down the line. So again, biosecurity, vector control in the face of Cache Valley, vaccines for the few vaccines that we have available for our small ruminants and abortifacient agents. And then again, consider nutritional screening of your dams to make sure that this isn't a deficiency that's causing our fetal loss. I have 4 minutes left here, and so I wanted to go through just one case where even under the best circumstances, where we get all three pieces, where we get the fetus, the placenta, and even maternal serum, we will miss the diagnosis in the absence of vigilant shepherds, vigilant and confirmed shepherds and herd managers that are really keeping an eye on our dams after they undergo an abortion event. So a few years ago, started seeing this kind of pop up on social media, and then I started I actually got a sample of this in the mail as a diagnostic submission. So what folks were reporting and sharing pictures of online would be that their does will have aborted a fetus about a week prior, and then a week later she's laying in her stall, and then when she gets up under her tail, you'll see these putty-like kind of concretions. They're very rubbery, they're pink, and they're kind of laying behind the dam and on the ground. And so again, the dam seems to be acting normal. She lost the fetus over a week ago, but yet here are these things. And what in the heck is going on? And if there was something tested in the fetus would have come back totally normal and non-diagnostic. No idea why that fetus was lost. So this is a very interesting entity. Let's see here. I've only gotten a few cases of this, but Dr. Joan Dean Rowe and Leslie Woods, Dr. Paul Plummer, some of our other giants of small ruminant diagnostics, they're the ones who more closely characterize this condition. And again, most especially Dr. Joan Dean Rowe. So this is a case of, let me throw this up there. placental amyloidosis. So in this case, it is an abnormal protein that starts misfolding in the uterus of the dam. So what you see is this very severe thickening and cupping and firmness of the caruncles. So these are actually maternal caruncles that are sloughing a week after the fetus was expelled. And again, it is from buildup of abnormal protein in that caruncle. This seems to be popping up more often in dairy breeds, but that's maybe kind of a false hearing because obviously our dairy breeds, we're not just breeding them for the fetus, we're also breeding them for milk. And so we're more likely to retain those dams after the reproductive loss. So maybe that's why we're seeing this more. I think I did have one case of this in a crossbred meat goat. So it doesn't seem to only be isolated to dams. But the main point of this is that once a dam develops this condition, she does not seem to be capable of carrying another viable pregnancy to term. And because the disease process is isolated only to the caruncle, there are absolutely no diagnostic findings in the fetus, in the placenta, or really anything that would screen for knowingly in maternal serum. And so in order to diagnose this cause of reproductive loss in goats, we really need to have our vigilant owners noting these and sending in these sloughed caruncles, or our very astute veterinarians to notice this abnormal thickening of those cotyledons prior to death. So again, this is a condition that causes mid to late term reproductive loss or stillbirth. There's nothing diagnosable in the fetus or the placenta, and we need to recover sloughed caruncles that only really pop out a week or more after that reproductive loss. So here's this is just a picture showing the brain from one of these fetuses, and what it's showing is that in green these are normal neurons, and in orange these are neurons that are actually necrotic. So what this is indicative is hypoxic death in the fetus. Unfortunately, that's not diagnostic because ultimately most of our fetuses die from hypoxia regardless of what induced that hypoxia. So that's not remotely diagnostic. And then this is a stain looking for amyloid within the placenta of one of these cases. And I think I went field by field at the highest magnification through the entire thing and only found two itty bitty fragments of amyloid within the placenta. So absolutely nothing that could be easily observed histologically, and not anything that can be efficiently screened for grossly or histologically in the fetus or the placenta. So again, something to keep in mind. Alrighty, I should stop talking now and see whether you folks have any questions.
Thanks, Dr. Michael. Like you said, if you have any questions, please put those in the chat box here. Just a couple reminders. I did put the handout for today's webinar into the chat box, and I also put in an evaluation link into the chat. So if people wouldn't mind clicking on that before we exit here today, that helps us with our programming, and particularly since we're going to be developing new topics for 2025, I'd be curious to know some new topics that people want to be hearing about in the next year. So I guess I have one question about, I guess, in your experience working with herds in the Midwest,
Mhm.
dairy goat herds particularly, what environmental stressors have you seen that cause abortion storms, and what have you seen producers do to maybe make some management changes on the farm to reduce some of that?
So again, abortion storms are pretty rare just from environmental events, but giant snowstorms, again, a very severe temperature extremes, so cold exposure, heat stress, often, well, not often, in the few times where we saw that in the history where it was provided that, again, we think that this was an environmental event, but we're just sending the fetus to rule out abortion, then it was a weather associated event. But when we have these non-diagnostic cases, the things that I'd be calling the veterinarians to ask about would be, was there recent movement? Did we just buy these goats from a sale barn? Did we stress them at the sale barn and then bring them back on home, which would cause reproductive loss? So again, it's weather extremes, it's animal movement, transitioning pasture, feed transition, something like that. And again, those would all be critical history items that our producers would be aware of, but may not make it to the diagnostic lab side of life.
All right, thanks. And one other question. So once you have a diagnosis with the fetuses being sent in, but you're still having abortions on the farm.
Mhm.
How does one handle those still fetuses on the farm? I mean, composting, or what's the best route to reduce, you know, the increased risk of biosecurity, right? With that's still
Yeah,
ongoing.
that's an excellent question. I'd recommend that producers work closely with veterinarian because it's going to depend on what that agent is. So obviously, if we have Coxiella, that is easily aerosolizable. So that is a much stronger consideration than say Toxoplasma, where we don't want our dogs eating it because then they'll shed it in their feces, and we don't want that happening. But that is less of a transmission risk to the rest of the herd. So honestly, to get it out of there, certainly. But then as far as the ultimate steps, would talk to your vet about how to best dispose of that. Composting would make sure that your dogs can't access this, wild animals can't access it and drag it back to your herd, right?
All right. I want to thank you again for being on our webinar here today. I'm not seeing any other questions in the chat, but I would say if there's any follow-up questions, you did list your email in the
Mhm.
beginning slide there. This is recorded, so we will get that up and back out to our participants. I guess I had a question here about posting the handout again, so I'll see if I can re-upload that before we leave here so you can grab
Mhm.
that. Otherwise, I'll do a follow-up email with the group and include the attachments for today's webinar.
Awesome. Well, thank you folks for attending. Appreciate the opportunity and have a great rest of your day.
Thank you.